So have we any questions at the back?
Hi, Ursula Collins with the Alzheimer's Society. As dementia is one of the main challenges in primary care, I wonder if your panel could advise if they think that a GP referral to a dementia-specific provider in the community is something that will be possible. At the moment, most patients that are either diagnosed or in the process of being diagnosed with dementia are not referred to an auxiliary support agency such as the Alzheimer's Society. Do you think that it's possible going forward that GPs will refer on?
So I think your question is that there would be a direct referral to the specific provider, and that's not happening already?
It's not happening, no.
Does the panel have a view on that?
Well, I think that you're a vital resource in the community. I think it's probably fair to say they're not being used, but I think it's very sporadic, and it depends on the profile of possibly the society in the area or the GP's lack of knowledge or knowledge of them. We certainly find them very good, and I think with scarce resources we will be begging to use you. I would love to use you. So I think it's a matter of getting it out there and using it. And I believe your funding, I think, was cut again, wasn't it?
Yes, yeah, we're being cut year on year for the last 3 years, but you know, we're continuing to try to innovate and put in cost-effective solutions like this. To enable us to move forward.
I think that you're a fantastic organisation, and I think that we need to use you more and all the other ancillaries or organisations, and that's why we've asked some of the organisations that we think that the patient advocacy groups have a great role to play in helping us. I mean, everyone is saying the same thing here. There's no doubt about everything. We're all saying we want to be at the front line, we want to be in primary care, but as will probably be discussed this afternoon, you can't ask people to do more things for less and less and less. There comes a stage, just like tax, you can't pay any more or you can't get any less. So, I mean, and it's very subtle the way the HSE sometimes employ these groups and give them grants, and then no one knows when the grant is reduced. All that means you have to fundraise more. But I think it's very sporadic, and I think you're a fantastic organisation. We certainly use you.
Thank you very much.
It's another question. Thank you.
Thank you, Mary Lynch from the Irish Hospice Foundation. Just to really comment on one initiative we're involved in with the ICGP and the HSE with SouthDoc, which is looking at supporting GPs inform the out-of-hours service if they can anticipate there will be a palliative need, and that can actually support then the SouthDoc service to anticipate the palliative care needs and support the patient in place. So it's really coming. We were looking for solutions, so there are some. It is really about tying up the services and passing on the important information in advance. And information on that is at the end. We have a stand here if people want more information.
Thank you. Has anybody a comment from the panel on that, or is there a question relating to?
Can I just say the same thing? Once again, it's dependent on your area, the services that are provided both at a hospice level and a GP level. I mean, you take the smaller the practice, the more you're likely to know your patient. But in a large area in a city, I see Frank Bradbury is here from CareDoc. I think what we do is if we write into the organisation, it's put on the computer, all the information is there, and when that call comes in, the nurse has the information for triage. And I think that, once again, it depends on the area.
I'd have to say, I think it's a challenge when you try to streamline services on a sort of a regional or global scale. And I'm involved with an organisation, a new organisation called the Primary Care Surgical Association, and we've had links with our sister organisation in the UK. And while it's very clear that community-based surgeons are providing services in multiples at a fraction of the cost that they would incur at the hospital, and we've heard this said already this morning, and debulking hospital waiting lists in the process, and providing the care to an equal standard of quality, if not better, with lower infection rates and complication rates, and much more conveniently for patients. Nevertheless, some of that specialisation within primary care does require attention to the knitting together of various services. For example, the out of hours with the day service. If a family doctor is not available to see a patient because he's doing a specialist service like in occupational health or travel medicine or skin surgery, he has to be able to hand over. So I think there's a lot of governance around all of that, but nevertheless I think it doesn't detract from the key message, which is general practice or family primary care care should be doing what it does well, cost effectively, and enabling hospital practice to deliver the kinds of efficiencies that we heard about from Jennifer earlier on.